How people call you? I've heard different ways of people calling you.
Yeah,
What?
so my name is like a big railway. It's Konstantinos, but they call me Dinos for short. It's a shortcut in Greek. So it's better for patients because this is easier.
Okay. So in this conversation, should I call you Dinos or
Yeah,
what do
yes,
you?
of course. Dinos, yes.
Yeah. Awesome. So a few years ago, when we got first to talk with each other, you talked about how you went to that fellowship with Dr. Shaheen Khazali. He's actually from the same country that I am from, and we both went in the same city to medical school. So I want to start with that. Like first thing I want to know about like how you got into Excision and like how you just because in this world it's very hard to go into Excision knowing all other things that's happening. And then I want to talk a little bit about multidisciplinary care in endometriosis and how you think about it and how you have approached it and how you think about excision versus ablation considering your background diving into excision and now how you see things in these two type of surgeries that people usually debate about. So first thing first, so this is the flow of the conversation. At the end, I'm going to ask you a few personal questions just to know you better and get to introduce you to the world a little more. How does that look like?
Perfect.
Awesome. So let's just start with you. Like, tell us about your background. Like, what happened? Why did you decide to become a doctor, and what dragged you into excision surgery?
Yeah, so it's a very long story. What is important is what dragged me into excision surgery. This is what people want to know. And I think my story is similar to most endometriosis surgeons' story. So I finished medical school, okay. We had some knowledge about endometriosis. Uh, then we went into specialty training. We learned more about endometriosis, but even then, all this area of endometriosis was very gray. It was like a gray cloud. So I finished the specialty training. I got my residency. I became a consultant. And even then, when I heard about endometriosis, I didn't know exactly what this condition was. So, like most of us, when we hear the word endometriosis, we think it's a cyst. It can't be anything else. So, endometriosis surgery would consist of removing cysts, just burn some purple spots around, and then we will give the patient some contraceptive pills or put them into a false menopause, and we have saved the patient. That's what most of us are taught in university and medical school. So during our training, our residency training, I remember we had many girls that came to the ER complaining of pain during period that they couldn't go to work. They wanted us to give them some days off work. And the what was very interesting is that they were the same girls. So every month, the same girls came to the ER complaining of pain. What did we do to these girls? We gave them medication, painkillers, contraceptive pills. I must admit, and I'm very embarrassed now, that we thought sometimes that these girls are more sensitive than other girls, or some of them may have some problem, psychological problem or something, or they wanted to pretend that they're ill so that they don't go to work and they go for coffee. Um, all these scenarios that drag us away from the medical part of the condition and makes us imagine if there's any psychological problem, which is unacceptable. Okay, now that I look back, myself and my colleagues, it was a very big mistake. But this is the only thing we could do at that time because we had too little knowledge about endometriosis. So after finishing my training, I became a consultant. Okay, so I continued having patients with pain during periods. I didn't pay much importance like most of gynecologists. And at one point, I went to a congress and I listened to someone talking about excision surgery. So at that time, I didn't know what excision surgery is. I knew how to remove a cyst. I knew how to burn around lesions. I could handle very well medical therapy. It's not a therapy, but I didn't know what excision surgery is. So then I started looking more into it, and I saw that it really worked. So I had to do something. I was fascinated by the treatment. So I contacted Sahin Kazali, who is a pioneer in the field. Like most Iranians are in their field, Iranians are very clever people and very innovative. And even they say that they will dedicate themselves in something, they truly dedicate themselves in something, and nothing stops them. So maybe it's the characteristic of your people. Mr. Kazali accepted me to be his fellow. I went there for 2 years. I followed him everywhere. So I learned too much, a lot from him. To tell you the truth, when I went there, I expected to see surgeries of removing cysts and ablate areas. So first week, I didn't see any endometriosis cyst removed. I saw bowels being removed, other things. I didn't understand what's going on. Okay, but slowly, time after time, and day after day, all this puzzle started going into the correct place. And this is when I realized that what I have been doing was wrong. So it's not about removing cyst or ablate lesions. It's about excising endometriosis.
So I think what you mentioned is mentioned a couple of critical points. I wanna open them up a little bit to learn from you and hear your perspective. First of all, do you remember who was the person in that congress that presented an excision and made you fascinated about this? Do you remember who that person was?
No, I don't remember that because to tell you the truth, I was paying attention, but not much attention to him because I thought that excision surgery, okay, maybe it's another thing not able to treat endometriosis. But when I got home and I Googled excision surgery and I saw papers, I started reading Dr. Redwine's book. After that, I saw that it's a completely new world for me. So then it is when I started to take it seriously.
That's amazing. So I think I think your situation is how I mean, I'm doing this series of discussions with experts who are leading the industry like to new edges. Like now we are somewhere, but now we are going to somewhere else. Multidisciplinary teams are being built, super complex surgeries are being performed. We are going to talk with you about that. So it's a new, like completely, we are seeing completely new limits. Old limits are not limits anymore. Now we are seeing new limits, right? So this is you building all this knowledge and experience, going to the right person to learn, starting from not knowing what excision was. I think this goes to really like people who listen to this, or surgeons, or like younger surgeons, or patients who have been working with other surgeons. Surgeons can learn and can be better and can improve. So if a surgeon wants to be really good at excision, they can be. And from patient's perspective, if someone was not good 10 years ago, they can go and learn and be good now. So always like have that in mind when you are a surgeon or when you want to work with a surgeon. I think that's a big lesson for me, because almost every surgeon that I'm speaking with has gone through this transition point, and that transition point has been important, which brings me to ablation versus excision, which is one of the main topics of this discussion. So there are some studies which show excision have higher quality or higher outcome, better outcome for patients. Outcome for patients is quality of life, pain, reoperation, fertility, like things that we know patients care about. But a lot cast doubt on it. Like they say, still we don't know if excision is truly the better surgery. From your perspective of like doing or thinking ablation is the right way because you didn't know anything exists, then transition to excision. What's your professional expert opinion on this? Like why ablation versus excision is always a topic, and why do you think excision is a superior procedure over ablation?
So, to tell you the truth, from what I have understood, the things that we know about endometriosis is much less than the things that we don't know. Maybe after 200, 300 years, there may be a pill which women will take and no one will have endometriosis. But at the moment, what we have is a combination of medical treatments, not a treatment, and surgical treatment. So when we have something abnormal inside the abdomen, let's say that we have cancer, is it better to burn cancer or to take it out? It's a reasonable thought. So if we have endometriosis and endometriosis goes deep inside the tissues, it's not wise to burn it, because if you burn it, you will burn the tip. So the deeper part is still there. It may regenerate, it may grow back. And what I have seen from my experience is that symptoms sometimes come back worse than before ablation, because you apply heat, you create more scar tissue. This scar tissue may cause more pain. So it's reasonable to think that when we have something abnormal, and this abnormal condition causes pain or other symptoms which interfere with the quality of life, we have to do something about it, and this is to excise it. It shouldn't be there. It's something that abnormal that shouldn't be there. So we have to excise it. So yes, there are studies that show that excision surgery offers long-term relief of symptoms, less recurrence rates, and better fertility outcomes. So we have to respect evidence-based medicine at all times.
So from your perspective, so do you think learning excision is a more difficult task for a surgeon to do, or learning ablation?
Yeah. So learning ablation doesn't require any specific skill set. Just to know basic laparoscopy, you insert the camera, you see where the lesions are, you burn the lesions, you apply heat either with a bipolar instrument or with laser. It doesn't differ much. But learning excision needs a lot of time. Not only, the first thing is to learn the forms that endometriosis can take inside the abdomen. So there are many forms. So in medical school, we are taught that endometriosis is a cyst, or, for example, a purple lesion. It's the most common lesion that medical books describe, which is not a very common lesion, to tell you the truth. There are far more lesions, many more lesions than that. And the second goal is to learn how to excise endometriosis. So learning excision surgery requires complete devotion, dedication. So you must be dedicated in this. So you cannot do at the same time obstetrics, oncology, infertility, and endometriosis. So you have to be dedicated. For example, I have abandoned obstetrics. I don't have time for it. I have abandoned everything else. I deal exclusively with endometriosis because the number of publications, the amount of knowledge that comes out every day is so much that you cannot keep up if you have if you're not dedicated in this. And also, if you want to become better, you have to deal with one thing from morning to evening. If you deal with one thing from morning to evening, you will get better and better and better and better. But excision surgery, yes, it takes time. But for whoever wants to go into this area, he will be able to achieve it in the end. That's for sure.
I completely agree. I mean, everything you said, and I really believe in having focus. Like, focus makes you perfect and excellent. I mean, there is no perfect in this world, but perfect for yourself.
Correct.
If you do only excision every day, all days a week, all weeks a month, all months a year, you're gonna get better at it if you are skilled and if you are focused and you're trying to learn. Whereas if 10% of your time is dedicated to excision, that's a
Yes.
different outcome
No.
scenario you're facing.
You cannot retain your surgical skills in excision surgery if you have, for example, one case or two cases every month. You have to have many cases on a week basis.
Yeah, that's amazing. I completely agree with that. So now, how many years are you doing excision surgery? Can you share that number?
The last 5-6 years.
5 6 years. So I assume, considering like the level of focus, you were with Dr. Khazali, now you're doing it yourself. So I think you have faced a lot of challenges and difficult situations. After 5 or 6 years, I can imagine you have great skills. Are there still cases that when you see them, for a second you probably get anxious and you have palpitation because now it's again a new word. I have to figure this one out. It's different than every other. Does it happen to you still?
Yeah, so endometriosis never stops to amaze us. When we may say that, okay, we have seen it all. Next week, we see something completely different that we didn't expect. But the most important is to have a very good pre-op assessment. So a good medical history, a good examination. So by following standard steps and not cutting corners around to finish earlier, etc. So these cases are rare. So you know what you will expect to see in the surgery. But even when things become difficult, this is when, for example, you may get help by a colorectal surgeon or by a urologist, or get another opinion. What should I do here with the bowel? So I'm very lucky because my assistant is not a trainee or a gynecologist. He's a very experienced colorectal surgeon. So he's with me in all endometriosis surgeries. He's holding the camera and actively assisting. So whatever problem we have with the bowel, we fix it right away, and we don't try to find where is the colorectal surgeon. If anyone is in the building who knows laparoscopy, who knows about endometriosis, this thing cannot work in endometriosis. So in endometriosis, you have to have people who know what you want to do and help you from their part. So even in times of stress, if the stress is relieved, is divided in 2 or 3 people, so it becomes easier and the surgery is more productive and more successful.
So I love what you said. So obviously you have to be prepared for surprises. You prepare yourself before surgery. I think that's incredibly important. Like having a plan going in, although maybe the plan changes the first minute, but we cannot go without a plan. And then you have the right team around you to support you in difficult times. Which takes us to the next topic, I think it's this next topic is extremely important, and that's about the multidisciplinary team approach for endometriosis, and what does that mean, and who makes a multidisciplinary team? Can you start from the beginning? So when you did your fellowship, go back to, I think you're in Athens, right? Am I correct?
Correct, yes.
So you go there, now you're this freshly graduated fellow with all this like experience and knowledge of so then what happened? Like how did you think about the multidisciplinary team, and then what's your philosophy of multidisciplinary team? Then tell us how you built your own team.
So, yes, it's difficult to build such a team. So in the beginning, it was difficult. I got rejected by radiologists who didn't want to deal with endometriosis. Okay, it was something. They told me it's something simple. We don't have to learn something more. But for the rest of the team, for the rest of the members, my colorectal surgeon, my urologist, and my thoracic surgeon, because we went into the same military medical academy, we have known each other since then. So they believed me, okay, that something more. But they have also experienced it in their careers. They have seen cases of endometriosis and they didn't have answers what to do. So we sat down with a cup of coffee, all of them. We started discussing, and what I was describing to them, they got thrilled. So they wanted, without any, they didn't bring any opposition to me. So they accepted right away that they wanted to become members of the team. And I think it's very important to have also personal relation with team members. It's good to know them, to be friends with them, because if you are good friends with them, at least for me, this worked. If you are already friends with them, the result comes smoother and they trust you, because it's very important for a colorectal surgeon. Colorectal surgeons are very skilled surgeons, very capable. Sometimes it's very difficult for a colorectal surgeon to trust a gynecologist. So, and when the gynecologist says it's better to do it this way, it's difficult sometimes for the colorectal surgeons to accept that. And okay, this is how it works. But having people who respect you in the team, and you respect them, of course, and have regular meetings, discuss with them, educate them, because you have to educate people. You have to be patient and educate the scrub nurse, the anesthetist, the urologist, the thoracic surgeon. But eventually it will come to the point where everyone is happy, everyone is thrilled, because motivation is also very, very important in endometriosis surgery. So that we feel that we have the feeling that we offer the best to the patient, to see the patient come back to us and smile and greet us and call us to say, hi, Dinos, how are you? It's very important for us to give to the patients their quality of life back. And this moral reward is extremely important. It is even important in other specialties which don't deal with endometriosis on a daily basis.
So I wanna learn more. I think I loved what you said initially. Radiologists didn't believe in you. So is this fair to say you are one of the leaders in the country, like in terms of bringing the multidisciplinary excision surgery to the patients? Is this
I
fair?
don't know. My patients will say that. I don't know.
Based on our assessments of the country and the region, in Europe, you are one of the leaders in the region. Okay, I might be There might be others, but it's fair to say you're one of the leaders in bringing new multidisciplinary approach to the team. So here we have this like recently graduated fellow coming from this fellowship program in the UK, and now I'm a radiologist. He's telling me let's do endometriosis. It's really scary. If I'm a radiologist, I want a safer path, not a new path with this new person with
Yeah.
this new idea, right? It was difficult. I think you really had a difficult time of convincing people, and people who work with you took a risk. If you think about this, right?
Yeah,
They took.
of course. They took a risk. But we sat together, we saw videos of endometriosis. They saw that, okay, it's not what they knew endometriosis was, it's something new. So they wanted to learn more about it, they wanted to participate, and they had a motive. They wanted to do that. So it's good to have people in the team that are motivated and they are happy to work with each other. Only this way can a team work.
Yes, I told you, like the team dynamic and
And
chemistry.
I also bought them a lot of drinks and a lot of cakes to persuade them.
I love it.
Yeah.
Bribe them basically.
Yes, correct.
That's awesome. This is like very cool. So what makes a multidisciplinary team in your practice? Like who are the components of the multiple disciplines that you have brought together to deliver the best care to patients? Like, can you explain
So,
that to us? Like,
yeah. Uh, we have my colorectal surgeon, a urologist, and a thoracic surgeon. They are dedicated in treating endometriosis. We have three anesthetists. One of them is also the director of the hospital. So whatever problem we have, we discuss with and she fixes it right away. I have a radiologist who was already very good in diagnosing endometriosis, but he got even better in identifying most of the lesions. I have an IVF specialist, and of course, people who participate in theaters like scrub nurses. So everyone knows his or her role. We don't have to discuss anything during surgery. We just look each other at the eyes. They know what the next step is. So everything goes smooth and nice.
do you offer also, maybe not in your team, but also at like network around you, pain specialists, physical therapists, dietitians? Do you have such network built around you?
Yeah. So yes. So one of my anesthetists is also a pain specialist. We have physical therapists inside the hospital and nutritionists. So whenever a patient is willing to take it a step further, she consults also with these specialties. But it's not the rule. So here in Greece, not many patients ask for physical therapy or a special diet plan. But because we accept patients from all over the world, we have all the specialties there under the same roof. So whenever we have we're in need or the patients need more advice about something, they can get advice and help.
Yeah, I mean, there are studies, especially I was reviewing a study just before this meeting, that how important physical therapy could be in long-term outcome of patients, especially with deep endometriosis, and only 7% of those patients actually end up having physical therapy. So they have pain and repeated operations about things that physical therapy could solve. Like as an example, I was talking with Dr. Ram Cabrera. Do you know Ram Cabrera?
Yes.
He's in Mexico and he's great. And he said something which I really am thinking about was like, as a patient, if you have a surgery with a good surgeon that you trusted and you have evidence that he was good, like for example, he's video vetted by other surgeons. So this is a good surgeon. Then after that surgery, if you still have pain, think about the impacts of endometriosis in that long time before the surgery, like sensitization, the spasms of the muscle, like, you know what I'm saying? Like how patients should also think about these things, which also goes back to multidisciplinary approach that surgeons could have. What's your thought on this? What's your thought on what I just said that Ramiro mentioned in that discussion?
Yeah, I completely agree. The goal every time is to treat the patient, not the condition. So every patient is different. So if a patient will benefit from pelvic physiotherapy, then yes, we have to recommend it. Or if patient may benefit from a special diet, we have to recommend that to the patient. But I think all these specialties are there for a reason. So each one can contribute something to the patient, and in the end, the patient will get the optimum result. This is the goal. So endometriosis treatment is not one-man show. It's not only the gynecologist's role. You have to get people who know more than you in their specialties to help you. So all these people around the patient, they contribute whatever they can, and the patient gets the optimum result. This is the most important. And yes, physiotherapy plays a major role.
Yeah, I really think so. You mentioned about, like, now we're talking about your center and your approach. You mentioned you have patients from almost all over the world. Can you tell us more about your center and like who are your current patients mostly, and do you
So
accept international patients if they want to work with you?
yes, so yes, we get patients. People come from America, from Europe, from South Africa. Some of them come from Middle East. We also had some doctors that came from abroad to participate in surgeries and see what we do, what is excision surgery. But it's very, very good because getting international patients gives us a very unique idea of what's going on in other countries in relation to endometriosis. So the problem that we have in Greece is also the same in almost all countries in the world. So because in the beginning I thought that maybe it's us in Greece that were left behind a little, but I think the problem with treating endometriosis and the number of years that these patients have to wait until they finally get a diagnosis, it's a worldwide problem and not a Greek problem.
So, I, I mean, obviously, this whole endometriosis is a global, in my opinion, disaster in terms of care. Like, no one knew what's going on. Now there are people making sense of it and creating new solutions. So I agree that problems are almost the same in most countries. Maybe some degree of difference, but in general, the same situation. So if someone wants to work with you, first, like, how do they get in touch with you? Like, if someone, let's say, from some part of Europe, from Northeast Europe, wants to work with you because they believe in you, in your work, what's the best way to get to you? Like, do you have a like a
Um,
direct to
an
them?
email,
Like,
yes. They go to our website and they just contact us via the email there, and then we exchange a couple of emails. We learn more about their condition. We get the details that we want, and once we have gathered and summarized everything, and we know what we are dealing with, then they come. They fly to Athens to be treated.
do you accept new patients now? Like, what's your general schedule now? Are you too overwhelmed with local international patients, or you are open to new patients?
Said, I'm still very young, so when I become 60, I may get overwhelmed, but at the moment I'm very young. So no, we're operating almost every day, so the current waiting list is less than a month.
All right, so that's great. That's amazing. What's next for you? What's your next big challenge at this point?
My goal is to organize a big congress in Greece regarding endometriosis. We have recently screened here below the belt, which went fantastic. So I'm trying to think other ways of spreading of knowledge, raising awareness. I think this would be probably a congress, both for physicians and patients, also people who want to attend with their families. Okay, it's a big goal, but I think this is the next thing to come in the following years.
I would love to be part of that conference, maybe as a
You will be
sponsor.
here. I promise to you. No, you will be here. Drinking mojitos, Shahid. You don't have to do anything else. Your presence here is very important, even by attending.
I'll be there, and yeah, I'm happy to help anyway. And
I think that your experience in the area of endometriosis is very valuable because you are discussing and having relation with many endometriosis surgeons, so you know exactly what the problems are, what the restrictions in every country. You have a global overview of the condition, and you have a better overview than each of us endometriosis surgeons separately. So yes, your presence, we will be delighted to have you here. And
thank you so much. I want to encourage you. I would love to have a conference, like for you to have a conference. I think that spreads the knowledge like nothing else. It spreads the knowledge and the passion and the energy for patients and other providers to come and learn from you. I think I really support you on that.
yeah, not come and learn from me. There are far better endometriosis surgeons than me, but come to a congress where many endometriosis surgeons will be there, renowned endometriosis surgeons, skilled endometriosis surgeons. I'm not putting myself in this group. I told you there are far better surgeons than I am. To go to an area, to a location where all this knowledge is there, and they can learn and they can grab pieces of knowledge. This is how society advances. This is how knowledge is spreading. This is how motivation is given.
That's amazing. I love this idea. I love it. So I'm gonna ask a couple of personal questions now just to know your other side, okay? Not all endometriosis. Do you do you follow any specific sport?
So I am not standing up like you are because I have a big belly. So yes, I'm trying as much as I can, but you don't have much time, much free time. You have to try hard to find free time. I wake up in the morning at 6 o'clock. I run a lot. I hope I will not die soon, young.
We need you. We need you. Don't say that.
Yeah. Yeah, I'm doing my best, like everyone else.
So I
So
was
I have
talking
heard
with
of. I thought about buying a bicycle and going to work by bicycle. Then I had another idea to buy an electric bicycle so that I don't have to pedal, to do the pedal thing and go with the batteries more relaxed. in the end, I didn't buy the bicycle.
I know.
Yeah.
Look, I was talking to Dr. Mali. I don't know if you know her. She's in Singapore. She's another top surgeon. She has also created a lot of changes similar to yourself. And she was saying, I stand during my surgeries. Probably that counts as exercise because she also doesn't have time to exercise physically.
Yeah.
Maybe that's,
Yeah.
I don't know if that counts
It's
or not, but
okay. Or maybe we have this excuse that we're working too much and we cannot find just 1 hour the whole day to go and exercise. But yes, personally, I try to exercise as much as I can.
maybe during that conference that you want to launch, we have to bring
Yes,
1 hour.
they will. There will be a special session for endometriosis surgeons how to train and
Right? That
get
would be actually a bad idea.
and get a six-pack, at least for me.
Awesome. I love this conversation. I don't want this to finish. However, I know you have had a long day and you might want to go. But is there any last word that you want to share with us? So first, I should tell you, this was my opening conversation with you. I want to continue this discussion, do more recordings because we have to spread the knowledge. We have to spread the experts' words out. And I love to do this more with you. But for now, this was the first one, and I would love to hear your last words. What do you think you want to share with the community?
That don't I would plead all people not to ignore when a lady comes and says, I have pain during my period and I'm not functional or I cannot have intercourse. Don't make, especially for the new gynecologists, for trainees that finish their residencies now, don't do the same mistakes that we did in the past. So only if you avoid the mistakes that older surgeons did, only this way can we can go forward.
That's very important. I think educating the providers, again, that conference could be a good movement in your region because just
Yes,
mentioning
correct.
it would increase the knowledge and awareness about the symptoms. That would be really important.
Yeah.
Thank you so much for your time. You are
So,
so great.
thank you, thank you. No, you're better than I am. Thank you for this discussion. Okay, you're a very pleasant person. I'm always happy to talk to you. And yes, we will have more discussions in the future for sure.
Yes, of course. I look forward to a really amazing future, and we will be in touch over emails and phone and everything. Thank you very much for your time.
Agreed. Thank you, Saeed. Thank you. Have a nice day. It's morning there,
You,
correct?
it's
It's morning.
n- almost noon, like 12 now.
Almost noon. Okay. Go get some break. Okay.
Yes, I will. Thank you so
Nice
much.
to talk to you.
Nice talking.
Saeed. Thank you.
Thank you.
Bye,
We'll
bye,
be in touch.
bye.
Take care. Bye bye.